Well, thank you. I'm happy to have the lights, Maya, as I feel like it's a press conference. Kim did a great job telling us from the patient point of view. Gil told us how we can improve things, and I'm going to tell you I don't have an answer for this question. But what I'm going to talk about, a little bit about economics, really, how it all affects you. Now, all those who went to the other room to hear about 6MP made a huge mistake. You can always learn about 6MP and hear those same lectures, but this is quite different. So what was the goal of the Affordable Care Act? We heard, Kim did a great job. You know, if I go online, I tried to do platinum, they rejected me. But in reality, it's to broaden access, which we know, modify payment incentives, and deliver the delivery of system redesign. And the goal, as Gil was trying to poke at, is changing volume to value, which we have a long way to go. But I applaud Gil and Corey and Josh and David for doing that. Kim already mentioned what's happened to healthcare spending. It's good to know from CMS that the percentage of the GDP actually went down this past year for the first time. It claims to be as a result of the Affordable Care Act. There's a lot of debate about it. And actually the number of uninsured has gone down significantly, about 5%. And Kim mentioned the 48 million or 50 million, now we're down to about 35 million, but that's a lot of people for a country of this size. So what is the proper target of resource allocations of our healthcare system? Well, one, should we only provide care that avoids errors of harm, but doesn't provide care that could produce improved health value? Or should we target a level where increased health benefits are balanced by the increased costs? Or should we target a level where we provide all care that is potentially beneficial regardless of cost? So this is a little diagram, and it comes from different economics papers. So there's one down there. I don't know where the vote is. So there's one. We don't do this. This is an economic optimum.
It doesn't show up.
I'm sorry. That's, yeah, see, I like the lights. This is an economic optimum, and this is a maximum impact. So where are we in the United States with this? So one's not realistic. That's not going to happen. What about choice two? Many policy makers and business leaders would suggest this choice. However, practicing physicians, healthcare professionals, patients, states, Medicare, Medicaid, behave as though choice three was the best target. But in reality, where are we? Kim alluded to this in the world, but we're somewhere in here. We're not here, and there's nothing here. So what we're doing, and you can see I have representatives here, Gil from California. I want to show him that he could be very proud of California, that he crossed the street. It's down here, California. So we're not doing very well. We're going to ask Rick and Steve Hanauer to have the meeting in Hawaii, because as you can see, Hawaii is doing the best in terms of outcomes and quality and cost. But many of the states are not. As you move down to the right, we're spending a lot of money, but not necessarily getting a lot of quality. So again, as we alluded to, what is really underneath the Affordable Care Act for you as physicians? Because what happens to you is going to happen to your patients. Well, cost containment is clearly there. Consolidation at all levels of healthcare, accountability, performance measurements, which we heard a bit about, and population management, whatever that is. So this is very important. We already know that our people are working on physician quality reporting systems. As Gil says, we have numbers. There's 33 from CMS. It was just reported 125,000 physicians in the United States report on quality, and they got a bonus of 4%. What's resource use? Resource use, in reality, is the lowest level of quality, which is all based on billing data, and that's who we are right now. So for example, if you had 100 patients with Crohn's and ulcerative colitis as a denominator, how many got a vaccination? So it's really billing data. That's actually where we are, and you're going to lose 7% if you don't start doing that in the next 5 years. It's still extremely crude. How many people here are using electronic medical records and are doing meaningful use? Okay, we have a bunch of people. Okay, so we at Partners and Brigham and Women's are one of the pioneer affordable accountable care organizations. We've been doing meaningful use for 2 years. Some of it you have to do. You have to do medication reconciliation. You have to do demographics. You have to do e-prescribing, and you have to reach a certain cutoff. And then our hospital gets money, and we each get $3,500 if we do it. and that's where we are. Still very crude, but there's, and year 2 of meaningful use is more complicated than not. Gil was referring to clinical practice improvement, win or lose 9% in the next 7 or 8 years, which actually means right now we have quality measures, but it's really billing data when it comes to insurance companies. And that is to give us an opportunity through CCFA, our organizations, our hospital organizations, to come up with true quality measures based on evidence-based. Right now our quality measures aren't really evidence-based. And then volume-based payment modifier really means if you do that, you'll either get money taken away or you'll get money back. And we're talking about 5 to 10 years from now. So does lower cost, does that mean fair? Well, CMS has been tracking this all around the country. And one area has been hospital-acquired infections. So that cost is $17 to $30 billion. It's on one of the lists for CMS. There's been a great success in reducing central line infections and bloodstream infections. But this isn't really cost sharing. What happens is you're working harder in your hospitals. We reduce these infection rates, but who makes the money? The insurance company. And that's actually part of the philosophical reason having pioneer accountable care organizations to allow them to set their own standards and see if you can save money. And actually in a report that just came out from CMS, of the 19 pioneer accountable care organizations, 12 of them saved a lot of money. Our institution got over $100 million back. But we spent about $150 million in getting the social workers, getting the physician assistants, and they're all in primary care. This has not touched any specialty from the government level, but it's coming. So what about consolidation? It's going to be important for you in your future and what you plan to do. Does it increase efficiency? And a recent paper in JAMA showed that hospital-owned organizations actually increase costs by 10% versus things like Atlanta Gastro, Minnesota Gastro, or systems where they have a very large number of specialists and primary care doctors. They were cheaper as physician-run organizations than hospital-run organizations. And why not? They can be much more nimble. So will GI people become employed specialists? Well, this is back in 2011. It's important to look at 35% of income from hospitals as of 2012 comes from you as employed physicians. And 19% of gastroenterologists were employed. It's probably up to 30% now. We hardly have a fellow out of 15 that doesn't go into some physician organization, hospital organization. You rarely see people going into small group practices anymore. So what about accountability? That was the purpose of having pioneer accountable care organizations. In September, they reported that it was very encouraging. There were 19, and we're one of them. 4 or 5 of them have dropped out. As I said, 11 of them made money and got money back, and another 4 or 5 have deferred for another year. And they're toying with the idea of what they call experimental payment models. Base payment is like the old days of withhold from the HMOs, that you would get 80% of the money. If you do perform well, you can get another 25%, you're going to get a 5% bonus, but a warranty component means if you don't, you lose 15%, so you'll be down to 65%. So having proper quality measures will be very important, not only the 33 that CMS has in terms of all specialties, but actually coming up with new quality measures that are evidence-based is the opportunity they're trying to give us over the next 5 to 8 years. And we've heard very nicely from Gilwood measures, but these are based presently in terms of insurance companies and CMS on billing data only. It's very difficult to actually, as Gil was starting to point out, we can do something, but to have hard measurements, it's hard. Actually, in our institution, we're doing SCAMS, clinical assessment management plans, as Gil mentioned, looking at our group of 9 people doing IBD, and do we get blood levels when it comes to a biologic? So far in our first 237 patients in 3 months, a third of the folks got levels because it's expensive, or the person, it wasn't the right timing, so maybe if we get our abstract accepted, we can talk about that. So that's very interesting about what do we really do despite these papers. And what is population health? Well, I think Miguel's going to talk about it. I had a long meeting when I was chair of public policy with the AJA with the head of Mass General, who's one of the world's expert in population. I sat down, I read the 500 slides, and I didn't know what it was, and we don't really know what it is. You can understand about a medical home, population health, you could take all your IBD patients, and put them under a, as you know, that's been done with diabetes and heart failure. So you have to hire social workers, physician's assistant, nurses. So you call the patients, make sure they come in, and make sure they're not coming to the emergency room and improve their health. So who pays for all those personnel? That's not so easy. Or, for example, in GI, one thought has been we can look at how you do in terms of finding colon cancer in a region, and you'll get more money if you did it properly based on your volume, and you'll lose money if you don't. So regardless of how you feel, this would be a daunting task to implement. Who's going to watch us? So where's this all going? Well, getting people insured doesn't answer how care will be financed or provided. That is the reality. And do we have the appetite for experiments? You all know in 2015 you're going to have your 5 billion codes with ICD-10. And the recent election is very important. No matter what we do, it's very important. So this is a little tree here. So Kim and I were talking about it very briefly. Well, in the next 2 years, nothing's going to change, because even if the Congress, which they're going to submit soon to the President to overturn the Affordable Care Act, he's going to veto it. It's not going to happen. But can we have some innovative payment approaches? With the change in Congress, will there be tort reform? Will anybody entertain a single-payer system? Absolutely not. When I was chair of public policy and met with the House and Senate, there wasn't one Republican in the House that agreed with this. Not one. On the Senate side, there was both parties. Now, on the right, in red, an attempt to repeal, we know it's going to be vetoed, but in 2016, if the White House changes, the Affordable Care Act could be repealed. So that's very interesting. So in summary, the ACA will go forward for the next 2 years because veto can't be overridden. Will we see a delay until 16? Will bipartisan efforts lead to locating a middle ground? Could there be a discussion about a single-payer system resurface? Probably not. Will tort reform resurface? Maybe very possible. So in the end, what do you do? If you're going to be retiring in the next 5 to 10 years, who gives a damn? It's not going to affect you. If you lose 2% of your income, you're probably rich by now anyway. But if you got a long way to go, and you listen to Doug Wolf or John Allen, our president of the AGA, you better get in a group that has 30 or 40 specialists, or join a healthcare organization where they can pay all the money to get you an electronic medical records. I don't see how you can afford electronic medical records. I just gave a grand round at 2 small community hospitals going to be part of the Mass General of Brigham. For these 2 small hospitals, $150 million to change their health care. The partners are going to put $1 billion in over the next 2 years to have a partners-wide health care, better electronic medical records, supposedly. So this is very daunting and very expensive. So with that happy note, I want you to enjoy Orlando. Disney World's out there. Have a good time and enjoy the sun, and thank you very much.
Thank you so much.